Good afternoon, and welcome to our Live with Leadership conversation during the National Ryan White HIV/AIDS Conference on Care and Treatment. Today, I'm grateful to have Gabriel Maldonado, who is the Chief Executive Officer and founder of TruEvolution in the Inland Empire in California. Gabriel, welcome.
Hey, Harold. Thank you for having me. It's good to be here. Good to see you again.
Good to see you again. We're here at the conference virtually, and the conference has been focused a lot on the work to end the HIV epidemic, which is a national initiative that many of us are engaging in, using the best of our scientific knowledge as well as applying the data geographically to the phase 1 jurisdictions, which are the 50 cities and counties that contribute to more than 47 cities and counties rather, that contribute more than 47 counties that contribute more than 50% of the new diagnosis in the United States, as well as the 7 rural states that have a disproportionate impact, a disproportionate HIV burden. And so in focusing both our scientific evidence, our resources, and our efforts toward those counties, Riverside and San Bernardino, which are 2 of those counties which you work with very closely, and your work with your terrific staff at TruEvolution. Great shout out to them as well.
Hey.
Jurisdictions that I had the opportunity to visit back in January before everything shut down. But can you talk to our audience and share just a little bit about some of the activities that you and other leaders in your area have undertaken to engage the community and government leaders in EHE efforts?
Yeah, absolutely. So, I mean, first and foremost, it's important to kind of contextualize the area we're in. Harold referenced to us as the Inland Empire, which has been for, as long as I'm a 4th generation product of the region. And as a result, I've always known it to be known as the Inland Empire, but it is both Riverside and San Bernardino County. And the 2 counties together make up approximately 27,000 square miles of geographic territory. I believe we are the largest HRSA jurisdiction, single jurisdiction, as far as land mass is concerned in the United States. We are larger than 5 states in the US. And I think that creates a certain set of very unique challenges, particularly around social determinants of health. And so when you're talking about ending the HIV epidemic and responding to disease education and prevention, you can't have that conversation without talking about mental health, without talking about housing, without talking about transportation, employment, education, the education system, not just health education, but the education as an institution. And so for us, when we first realized that we were going to have the ending of the HIV epidemic, we wanted as an organization to ensure that this was a multidisciplinary and multi-sectoral approach. And so we have an initiative called the Health Equity Advancement Lab, or HEAL, H-E-A-L, HEAL. And the initiative is really to do 3 things. One is to partner and work with government officials, public officials, and that includes both the electeds and the administrators over our local county agencies. 2, to work closely with the community. So that is clients, that's patients, that's the end user, that's the person that is receiving the services. And 3 is to bring together the workforce. So that includes not just your CEOs or your director of programs, but your case managers, your linkage to care specialists. And so you attended at the beginning of this year, we hosted a 2-day leadership summit and community caucus. And we were able to get either the director or the deputy director from our local Department of Health for both counties, our local Department of Social Services for both counties, the Housing Authority, Department of Mental Health, Workforce Development Board, and the Department of Education. And this was for both Riverside and San Bernardino. We also had the State Office of AIDS there, and the EHE team for the State Office of AIDS, Kevin Sitter, and the Leroy Blea, who serves as the consultant. And that's a big shout out to Kevin and Leroy for their amazing work that they're doing, and they're very big parts of planning this summit for us, and specifically our community caucus. And so the community caucus was an opportunity to work with the 5 largest primary service providers. So there's about 5 of us. There's 6 of us if you include Arrowhead Regional Medical Center, which is more of a hospital facility. But there's 5 community-based providers in our region that make up the bulk of HIV services. So we reached out to all of them, and everybody sent at least 5 to 10 different clients from each of their agencies. And we gave an opportunity for Harold, yourself, and representatives from CDC and HRSA to kind of spend several hours in these small mini groups talking specifically one-on-one with the community. And then that Monday, we hosted our leadership summit with all of the heads of the different agencies. And so our approach has really been to respond from a social determinants of health framework and to kind of look outside of the public health sphere and try and draw in other agencies. So that's just in short, a little activity that we did this year for the EHE.
So that's perfect. You all were able to get a lot of these pieces in place and underway as part of your community planning process back in January. But can you talk a little bit about how that process has been impacted and the work has been impacted by COVID-19?
Yeah. Well, everyone's lives changed, at the end of February, March. And, for us, we became part of the state of California's rapid housing response, which is known as Project Room Key in the state of California. And so our county called upon us to be Project Room Key providers. And we took on the largest number of people living with HIV. I believe all people living with HIV who were housed during the Project Room Key period all have been referred to TruEvolution. We took on that scope of work. And so we currently have about 70 clients scattered at 18 sites across Riverside County specifically. That's the county we specifically responded to for this initiative. And so we've been working over the last few months to try and provide telehealth services in partnership with Borrego Community Health Foundation, which is our local FQHC. And then we also are responsible for the permanent housing placement of these clients after Project Room Key's initiative ends. And kind of during that window, we have a lot of clients that I just got off a report with my senior team that talked about staff are having like extreme mental health stress, extreme substance abuse and substance use challenges with kind of the anxiety of being cooped up in sort of this single room facility in a hotel for long periods of time. So we're really trying to not only respond to the disease prevention aspect of Project Room Key, but really to kind of create a mentally stable environment, particularly for some of our clients that already had existing mental health issues or substance use issues already.
So you talked about in Riverside and San Bernardino being one of those 2 county areas. And at one point, I was very young, project officer for Riverside, San Bernardino. And I never forget in their grant application, they talked about the fact that they are, as a 2-county TGA under Ryan White Part A, that they can fit geographically into New England from Connecticut to the Maine border. And so, when we talk about transportation as one of those social determinants of health, talk about sort of that impact on your area. You talk about housing status, but, having been there and driving.
Yep. Yeah, no. And actually it's so interesting, like transportation is probably like the smallest conversation we often have around HIV in our county, but it's the biggest conversation that the county at large always has. And that's mainly because, let me contextualize it this way. So if you were a client in, say, Upland, California, which is in kind of the far western side of San Bernardino County, it's on your way towards Los Angeles. And let's say you go to the AIDS Healthcare Foundation that's located in Upland. But then let's say you have to get your housing support or you get your substance counseling from the Desert AIDS Project in Palm Springs, okay, which is in Riverside County on the far eastern side. And that's very common. You remember I told you earlier in the conversation, there's really only 5 of us. So it is very common for a client to have to go to 2, sometimes 3 providers, depending on what their services that they need, And so the distance to get from AIDS Healthcare Foundation in Upland to Desert AIDS Project in Palm Springs. It takes longer to make that trip on public transportation than going from the Fenway Institute in Boston all the way down to a local organization in DC that I'm close with called Us Helping Us in Washington, DC. And you can make that commute from Fenway to Us Helping Us faster than you can from one part of our TGA to the other part. It can be up to 8 hours on a bus. And because we do not have an intra-county transportation system, you often have to go from one end of the county, make your way to the border, hop to a new bus, and then you take the bus from the rest of the way out to however far in the eastern county. And so it can really create a lot of significant challenges when you talk about linkage and retention efforts and being able to get people from their doctor's appointments. So that's a real challenge.
So as you all approach planning for the EHE initiative, how are you looking at and hoping to address some of these systemic issues like transportation that impact access to care, or you all also as a multicultural transitional grant area, 2 counties. You have language issues and barriers as well with your populations. How are you looking at tackling some of these issues, and what's sort of the overall approach?
Yeah. Well, you can't see it, but I have a photograph right here of James Baldwin, and James says, he says that it's racism in history is not the past, but it is the present, and it's not just, looking at what was, but recognizing what still is. And that the Inland Empire, actually, that actual terminology has history born out of the Ku Klux Klan. And the KKK actually had one of its largest chapters in California, in the Inland Empire, a very, very significant chapter in the Inland Empire. And also California has, I believe it's the, I'm trying to remember, the Southern Poverty Law Center, I think it might be them. But there is a list of kind of where all of the major hate groups and the number of different hate groups and where they are located. California, I believe, has the highest number of different hate groups sprawled throughout California. And so while our local state leadership certainly is very progressive, and certainly there is a majority of a certain kind of a philosophy of approaching at the state level, in our local counties, we still have a deeply rooted history of racism and violence in some of our local communities, particularly when you talk about those that are documented. San Bernardino County is home to one of the detention facilities and the detainment facilities for those who are arrested by ICE. And so there's a lot of unique layers, and we have a very large indigenous community. And, often we don't, the indigenous and native community is left out of the conversation altogether. So there's a silencing of their disparities that have been going on for a very long time. And so I think our approach is really, I'm going to say this word again, this phrase, social determinants of health. I think that our biggest client population is dealing with issues outside of HIV. And so when you talk about addressing racism, creating safe spaces, creating the ability for a community to engage in more than just HIV resources, but that they can come to you for a whole host of things to meet their needs. I think that's one of the ways that we can, redirect people's experiences from institutions that may create a racist experience for them, and really more so look at prioritizing, emboldening, and giving more resources to the institutions that can provide that wraparound experience in a very culturally responsive way, if that makes sense. And that's kind of what our efforts is just to diversify our services. When we expanded into our mental health clinic, and now we have a housing program that's actually larger than our HIV program now. And I think that by trying to meet the needs of clients from multiple perspectives, you can slowly begin to transform the experience of your clients, and then continue on the advocacy front when it comes to changing the system itself.
So before we go to our questions that are coming in the chat box, and for those of you who have questions, please, we invite you to put them in the chat box and we will get to them. One other quick question before we turn to the chat. Gabriel, have you found that, during this time, both with EHE funding and everything that's going on in the country, that being able to have these conversations about systemic racism and their impact on healthcare access and healthcare delivery are easier? Are they more open to understanding, or has it always been that way where you are in your part of the world?
Well, it is never easy, nor should it be easy, to have a conversation about racism anywhere in this country. And it is still a challenge for us today. What I think these times have done, though, it has created a situation in which the institution and the system that has for so long been comfortable and been able to silence and to ignore and to pretend that some of these issues were not happening, they are now confronted with a very real reality of a population that is not tolerating this injustice any farther, at least within this generational group. This generation is over. And when I say this generation, I just mean all people that are living in this time right now. They are not here for it. And I think that real reality that elected officials are going to have to confront the fact that they have a constituency, both from people of color, but also our white allies who do not feel that this is any more acceptable. And I think, to have some of the images that we've had on the television and on our YouTube channels, I think that has created a situation where you would literally have to be racist yourself. And I'm going to say that you have to be racist yourself to not have this conversation, because even silence against racist activity is perpetuating the racist paradigm in itself. And so you just can't be silent anymore. There's no longer a comfort space for people that want to be silent. And I think that is what these times have opened up, is compelled us to have a conversation.
Thanks. So one of the questions in the chat box is, in your opinion, what role do you see for technical assistance provider organizations in supporting the EHE work that's happening at the community level? And where do you see gaps in skills and knowledge around technical capacity?
Excellent question. I really appreciate that. So I'll answer it in two ways. The first one is that the kinds of technical training that's offered needs to be diversified. Especially, I'm going to speak from the perspective of smaller community-based organizations. We need you to teach us how to use our QuickBooks. Okay, we need you to go back to the basics. We need you to help us to do the basics and evaluations. When you talk about becoming a community-based provider that is funded through private dollars, and then all of a sudden now this EHE creates this opportunity, I tell everybody who's excited, oh, hold on now, because your finances and the reimbursement process and creating units of service, that is a lot more of a complicated idea for many of us than what we were prepared for, certainly than what is our orientation. FQHCs and clinics, they already have an orientation of being able to recognize their services in these kinds of very transactional, documented ways. But for community-based organizations, sometimes we don't recognize exactly what our work is, how it's kind of factored in government language, and being able to translate that for us from a financials perspective. I would say that's one. The other angle of this is that, often my SIBA experiences have been very consultative, and we're going back to school, where you're going up, you're doing a PowerPoint, and you're teaching me in this lecture style. I don't got time for that anymore. I actually put my dollars to hiring consultants, someone who comes in, I tell you what to do, and you do it. So if you're going to do a SIBA on evaluations, you need to leave us with the tools. You need to build them for us, build them with us, and then leave us your tools. So they need to be open source. They should not be proprietary. And I think sometimes when SIBAs have overly proprietized, training materials, it doesn't really do us any service, because we're going to have staff that are going to come in for years to come. And so we need to have the actual tools in our hands to be able to use them. And that hasn't been my consistency in SIBA experiences, that they've always just come in, do it, give us the tools, and let us get back to work. That really hasn't always been my experience.
So it sounds like sort of that mix of TA, especially when there are things that have to be done right away and on the ground, being able to have consultants come in, work collaboratively with you and your team to develop the tools, the resources, lead you all to implement them. And then, when there is time for sort of that didactic lessons learning, training, skills building, but sometimes having technical assistance that can help you build that infrastructure and those tools that you need is also needed. So that's a
the I word, I would use the I word, infrastructure, like you said. That's the key word. You need to add value to the infrastructure, not just be consultative. You need to leave something behind,
That completely makes sense. And especially when, we've got 9 years to end the HIV epidemic under EAG, we've got to get moving. So this question comes in, and I don't know if you've seen this or not. There's been a lot of conversation about the impact of COVID-19. And this question is about, have you seen any increases in new HIV infections or STDs during this challenging time of COVID-19?
That's a sort of a hit or miss. Certainly, I have seen increased rates of STDs. I have seen that, and a lot of folks are engaged in stress sex, and that is very real when it comes to the times that we're in. But I also think that the availability of STD testing is a little scarce and sparse right now, because a lot of clinics are sort of scaling back and modifying their hours of operation. A lot of clinics are in telehealth, and if you do need an in-person appointment, it may be a week or 2 weeks before you can come, because there's a restriction on the number of patients per day, per hour in the clinic. And so I think there also just may be a lack of testing that's happening right now. My organization is still offering HIV testing. There are certain organizations that are not offering anything in person, period, especially if they don't have the sort of clinical infrastructure to be able to, we've had to invest a lot of money in these scanning kiosks that are outside the door to check your temperature with the PPE, with this thing, it's not easy, and so for us to offer HIV testing is a real risk to our workforce. So I also think that there may be a lack of testing in certain areas, but I certainly know anecdotally that I've heard from staff, and I've also heard from colleagues and stuff, that there is a lot of stress sex that may be resulting in certain STDs. But I also know a large number of people who are practicing complete isolation. I do know quite a bit of folks that have taken any kind of sexual activity completely off their table. And that is a very unique group of people as well.
Yeah, I think you're right. And what we have been seeing sort of at the federal level is that, there has been reductions in the availability of HIV testing. We've tried to promote HIV self-test as a way for individuals who need a diagnostic test to give tests. We know that many public health departments have scaled back or are deployed staff to address the COVID-19 components and epidemic, and that many community-based organizations have also tried to step in, like yours, and fill that void as well. But at the same time, we also know that there are using sort of a trauma-informed approach, that sort of those coping mechanisms of sex and alcohol and drugs, and individuals are sort of relying on them to get through this very stressful time, which also puts them at risk. So we will see what happens when surveillance, HIV surveillance and STI surveillance come back online, and where that leaves us. Another question has come into the chat, because we still have a few more minutes. What recommendations would you make to the federal government to facilitate implementation of EAG in your community? Okay, Gabe, be kind.
Ooh, I was gonna say, don't ask me that question. I said, I know we only have a few minutes, and Harold is my brother, so I don't want to put pressure on this. I served on the President's Advisory Council for HIV and AIDS in the Obama administration, and you know, I was so enthralled and excited and giddy at some of the really progressive, comprehensive conversation around addressing all of these different things and nimbleness and disruptive innovation. And yeah, you can buy a mobile unit with the EHE money. Yeah, you can do all this, you know, yeah, possibilities. We're working on the our EHE NOFO right now. It's not that easy, and it's not as nimble, as flexible, as responsive as at least I heard when we were all excited around the tables talking about how exciting it was going to be. It's not quite working out that way. There's restrictions, there's limitation, there's county regulations, there's state regs. You have to get waivers for this and that, and it really isn't as nimble. Government still is government. And so my recommendation would be that, you know, however is appropriate for federalism and the different roles and responsibilities between state and county, I think there needs to continue to be very specific guidances, at least guidances that allow for the flexibility and nimbleness. Because often we talk about guidances and policies, it's often restrictive. It's often, you know, HRSA slapped your hand. And so HRSA slapped your hand, so the state implemented some, you know, really intense oversight policy that actually creates a bigger challenge for us, right? It's these negative responses. But I also think we should have guidances that really urge and keep both states and counties in alignment with the spirit of the nimbleness and the disruptive innovation that we call for when we have these conversations in DC, and not just look at the big bucket pillars and the overarching frameworks and the large indicators, right? But really be comprehensive about the implementation. And the last one is that you know, my organization is going to be heavily restricted in the amount of EHE monies that we're going to apply for. I actually can see that our grant writer, one of our grant writers, has joined is one of the attendees. So shout out to Norma. We love you. And you know, I've kind of pulled back on the amount of funding that we wanted to apply for because it is a reimbursement method. And as a small community-based organization, you know, I can't float a, you know, combination of $1.something million combined from our various reimbursement grants. I am not able to survive the cash flow on floating that across all of these different contracts from multiple agencies. So I think if the federal government could really create a remittance process that was responsive to organizations that only have 3 to 4 months worth of cash flow, 1 month worth of cash flow. And, you know, a lot of the big entities that I speak to, they tell me that even if they didn't have lines of credit, they wouldn't have the cash flow. And these are big multi-million-dollar agencies. You know, so that would be my final point, is if we can look at the method for how we pay our providers and recognizing that not all of us are in the same financial position. And that doesn't mean that we're unstable. It doesn't mean that we're not sustainable. It just means that the system has not really been responsive to creating a financial environment that allows us to have a large amount of cash in the bank at one time to float some large contract. And so that would be my final recommendation.
No, that's a good one, and definitely something that I feel like we need to think about, especially since later in this year, there will be an additional round of funding through EHE geared toward community-based organizations. So we do need to think about what are some of those restrictive policies on the state and local level, as well as the reimbursement mechanisms that might get in the way of those organizations working with us effectively. So Gabe, I want to thank you because unfortunately, you know, we've run out of time. You and I could probably talk on about another hour or so.
Absolutely, yeah.
But our half an hour, we have run out of time. So I want to thank you for being with us as part of this Live with Leadership talk during the conference as well. I would encourage those of you that are part of the virtual conference to join us this evening as we have another talk with Heather Houck, who is the Deputy Associate Administrator for the HIV/AIDS Bureau at HRSA. That's going to take place at 6 p.m. Tonight. We also encourage you all to sign up for updates about ending the HIV epidemic on hiv.gov. You can see it on the screen right now. It will definitely keep you up to date on everything EHE. And then if you're not able to join us tonight, then tomorrow night, we are having both Dr. Laura Cheever and Heather Houck from the HIV/AIDS Bureau sort of wrap it all up before we sort of take it all home and talk about 30 years of HIV care and treatment, and as well as the conference. Gabriel Maldonado from TruEvolution, you and your staff out there on the front line continuing to provide care. I want to thank you all very much for the work that you're doing. I want to thank you for your EHE efforts. And I also want to thank our participants for joining this afternoon. And I hope that the rest of you enjoy the rest of the conference and come and join us later for our next Live with Leadership talk at 6 o'clock tonight. Thanks.
Awesome. Thanks, everyone. Thanks, Harold.